come back into our regular work session at 5 minutes after 10. We'd like to welcome Stacy Michelson from ALC, Association of Oregon Counties. And she's here today to give us an informational presentation on our mental health authority. So welcome, Stacy.
Thank you. Denise, I am going to ask, help me find my presentation view.
I don't know how to do that.
It's up above, I think. It's slideshow.
Yes.
Click on slideshow right up
Right there? Okay, that was my issue. I could
No,
not see.
slideshow,
Oh, yeah.
right there.
There you go. Ah, thank you.
Right
There you
there.
go.
All right.
And then from the beginning.
There we go.
There you go. And I'm not a computer person, so.
Well, I just couldn't see that far, so.
I know, but you.
So first I want to give credit where credit is due. I plucked this slideshow from Silas Hallerensteiner, who's the HHS director in Yamhill County. And just recently he did our presentation at County College on the local mental health authority. So it was very nice that I was able to just kind of use what he had already put together with folks. So I know you'd all asked for a quick overview of sort of the county responsibilities as local mental health authority. And just very quickly, I think for the most part there's a lot of similarity between local mental health authority and local public health authority responsibility, insofar as they are both statutorily defined and laid out that the county board, unless has otherwise been decided or contracted, does have that responsibility, and there are some specific duties that are laid out in Oregon statute regarding that. There are some differences that will come up as we go through this between public health and mental health, particularly around how some of those services get delivered.
So Stacy, before you go on, because you just said something kind of interesting, I was trying to make sure I heard you right.
Sure.
When you said unless there's some kind of contractual or otherwise, are we talking about the authority? That there's
So-
a way not to be the authority?
That has actually, and I believe that is where one of the distinctions comes in. I believe with public health, there are still, that is a fair point actually, yes. The authority stays with the county, but there are ways in public health that you can sort of designate out some of that responsibility more than with the mental health authority.
With mental health, we have to turn it entirely back to the state to get out of the mental health authority. Am I correct on that?
Yes, to have no authority responsibility.
Okay.
Although there are some other creative solutions that folks have come up with. And I guess that would kind of be my overarching takeaway from all of this is, as you're thinking about this, or if you have questions about how you want to handle the mental health authority, consider some creative options. First, I think from AOC's perspective, it always seems beneficial where folks can keep things in the county, because when you hand things back to the state, you really are washing your hands of it and kind of giving up, yes, your authority, but also your ability to have much say in how services are delivered and to be responsive to your local community needs. And you can talk with a few other examples. I know Umatilla County just recently took back their authority from the state because they had handed it over and decided that they were not happy with how that was.
It's a vicious cycle.
It does happen. It happens on both sides. So a few different acronyms that you'll see as we go through this. The LMHA is the Local Mental Health Authority, and then CMHP is your Community Mental Health Program. And the distinction is that, as you pointed out, yes, the authority rests with the board or local government, and then the Community Mental Health Program is the provider, which may be the county or maybe another local entity.
That first bullet there, question right off, is it says that we appoint the director designated community mental health program. So we've contracted out. So are we still responsible to designate the director to appoint?
To appoint the director. I believe that, and I can double check with Rob, my understanding is that through the contracting process, that would count as having appointed that director, because you are still selecting.
Because we've had our contractor hire their own director, which would be the director for mental health. We work well with them, but
Sure.
I just want to make sure we're following our
Right.
guidelines that we have to do. So that would be my first question.
Okay.
to you.
And I'll make a note of some of these very specific pieces.
And I've probably already blown your presentation with questions on the first bullet.
No, this is fine, and some of these are more detailed than I often get. And I know that folks are just still in the process of approving the 1719 contracts with the state. I think DOJ has gone through things. I've seen some amendments on the public health boilerplate language. I haven't seen much on the mental health piece yet, but, and I know that, there are regular discussions back and forth. And I can go back and take a look at the contract. It's about 50 pages of boilerplate language and see if that is answered through that question or not. I'm just gonna make a note, so I just wanna make sure I get back to you on that. Okay. So very quickly, it just sort of lays out, and you're probably already relatively familiar. There are both responsibilities on the state laid out in statute to help you all establish your mental health and developmental disabilities programs. And then, as you can see, so does either counties, regions, or tribes who do retain that mental health authority. We do not currently have a regional mental health authority, so far as I know, but you do see that with public health, with North Central Public Health District, which is an ORS 190. So that, again, in terms of thinking about creative solutions, could be something that folks would want to consider before they looked at simply handing back the authority to the state, which is always a little bit of a challenge and a question. I think in some of our rural communities, on the one hand, it seems sort of intuitive to partner across borders and share resources, but then there's often the issue of not always being able to get the same economies of scale, that are more common in some of the more metro area. And so the conversation, just a big Commissioner Brown, there are pieces that are laid out in statute, and then it really is sort of up to the local authority to determine to what degree they fulfill some of those responsibilities. And there is, as we see, as we'll move on a little bit later in the slides, there's some specific language that also makes very clear that some of the work is dependent upon availability of funds. And so it does give you all, as the LMHA, the flexibility, sort of determine how you want to prioritize the dollars that you get from the state, and which programs you want to, or programs and services that you would want to focus on, again, based on the needs of the local community. And I can get the slideshow to you guys too.
That'd be great.
And so this gets a little bit more into the local plan that was mentioned on that last page. And this is, as you see on that last bullet, this isn't necessarily an every year plan that needs to be submitted. So I'm not sure when Lake County last developed their comprehensive plan. As that bullet mentions, it is something that the agency can on occasion require folks to revise. But there's nothing that prohibits you from revising that as you would want to do at any given time. I will point out on the CCO bullet point there, that second one about coordinating the plan with CCO. I think this has been an issue that's come up a lot as we've moved to the coordinated care model, and does bring some angst from a number of advocates. I know that there is often an impetus or a directive to work with CCOs and coordinate with CCOs, and it often seems that that responsibility falls to the entity that is not the CCO to make sure that that coordination happens, and is not always directed to the CCO to partner with others in the same way. So what this really says, while this will vary depending on area of the state and the local government's relationship with their CCO, It may be a matter of sitting down together and working on a joint plan, but this really says that as you are developing your plan, you will take into consideration the community health improvement plan that the CCO has developed. You do not have to have the CCO at the table. You just have to have looked at what they have already developed and kind of figure out how that fits into the work that you are doing locally.
I really wish that this would have been a mental health advisory board meeting also, and all them would have been there.
Yeah.
It really, maybe error on my part, not making sure they were all invited.
You know, well, as we were chatting, you have me through part of August, but then there are some other folks that I'm happy to, connect you all with, and I'm always happy to get folks
Maybe we
out as a
could
resource.
Maybe we could arrange something before the middle of, I know it's tight time frame, but it's Stacy.
It would probably be good.
Because I know Denise invited the hospital today, our provider and our contractor.
Sure. But yeah, I mean, anytime, we'll make sure we can get somebody down here. So again, going through some of the ORSs, you'll have the community mental health program. This is responsibility of OHA in coordination with local governments. And this is where we get into the legislature gave counties the option to establish and operate a community mental health program, which can also be contracted out, so we'll get to that. And then the LMHA has the responsibility, again, to determine the need within the community and develop the plan that reflects the local need. The community mental health program, this is where we start to get into services, and this is further defined in the contract, and that you all will be, well, may have already been signed actually at this point for the 17-19 biennium that lays out sort of the specific requirements for each area. But the breadth of services often included in that domain of the LMHA, screening evaluation, crisis stabilization, vocational and social services, that's going to fall a little bit between mental health and the developmental disability side of things. And we sort of lump the local mental health authority and the developmental disabilities piece kind of together. They are distinct. It does become interesting because mental health lives within the Oregon Health Authority and developmental disabilities lives within the Department of Human Services. But in terms of how those function at the county level, it is usually the mental health departments that oversee the developmental disabilities programs. And in terms of our affiliate partners, it is the Association of Community Mental Health Programs that also does most of the advocacy at the state level around developmental disabilities programs. And they have some staff who are dedicated to that specifically. Continuity of care with housing, we see that as part of our housing work overall. Health, social services, psychiatric care, residential services. Obviously that is not something that all counties are going to have in-house. Meds monitoring, counseling, therapy, public education, which ties in with public health in many ways, prevention, mental health promotion. Manage the crisis system and children and adults entering or transitioning from the state hospital or residential care and community-based specialized services. I do want to pull out the state hospital piece from that specifically. I don't recall off the top of my head what the rate for Lake County is. I don't believe that you all are very high utilizers. But we do actually, for some of our smaller counties, Klamath and Douglas in particular, have been incredibly high utilizers of the state hospital compared to the population of the county. Pure numbers, it's not surprising. It is some of the larger counties that send the highest number of folks to the state hospital. But compared to the county population, Klamath and Douglas are also incredibly high. And that's something that the Oregon Health Authority is really focusing in on, and it does make a nice nexus with AOC's work around public safety and mental health partnership, trying to find a better way to serve folks in the community Not only on the very front end, trying to prevent folks from getting into jail who don't need to be there, it could better be served through mental health services in the community, but particularly trying to stem the tide of folks getting sent to the state hospital. And that's one area where we find a really nice partnership between local government and state in terms of priorities.
During this session, Stacy, I don't want to get us going sideways, but I'm thinking about all these services and the cost, and historically, a lot of the clients and where those dollars come from. So my question is, how much discussion was around Medicare and Medicaid and nationally the abuses that they've been identifying and how that might affect long-term those types of services?
Sure.
Because it's a huge issue right now.
I would say this session was a hard one to answer sort of that specific question. I think in a different environment, there would have been more of a focus around, for example, the Secretary of State's audit report that came out, and there was a response to that. But I think in this particular environment, there has been so many unknowns around what healthcare looks like at the federal level, that folks seem a little bit stymied at the legislative level. It was kind of this, we need a plan should things continue with the status quo. We sort of have to operate with the information we have available, but there is obviously a very large question mark regarding what federal funding may look like in the future. So I think that was in the back of everyone's minds, but it was not really directly addressed through the budgeting process, simply because we still have to operate with programs that exist currently and figure out how to fund those. So it is an ongoing discussion and question. As you all are aware, there's still some back and forth around whether the provider tax that was approved by the legislature remains intact or not, whether we're dealing with a $600 million budget shortfall in the 2018 session remains to be seen. So there's a lot of ongoing head scratching at this point, I think, really around what these pieces look like. And I will say, things, so for example, the Medicaid and Medicare piece, and this is an issue that we have advocated for at the federal level. NACO has pushed on it. Unfortunately, it really is just a matter of cost, largely. As you all are aware, for folks who are on Medicaid, as soon as they're booked into your county jail, that shuts off. We have at least gotten to a point where Medicaid is suspended versus terminated, but it won't cover folks in a public safety setting. Same thing for the most part has applied to the Oregon State Hospital, and it kind of goes back to a historical issue around moving away from institutionalization of folks. But it does still mean that when folks enter the state hospital, that's purely coming out of Oregon General Fund, about $1,000 a day. It's somewhere between $950 and $1,000. So for folks who are there for very long, it adds up fast, and that's where we know that it makes much more sense if we can serve folks in the community before they get there. I will say a quick caveat to that, and this is a credit to the former Superintendent Greg Roberts, who had done some similar work when he was with the state hospital system in New Jersey. Did get some certification around the state hospital that does allow for some billing of Medicaid, which is pretty big for the state budget. It doesn't completely open the doors to bill Medicaid, but for some services, the state can't get Medicaid reimbursement for some of those folks.
Well, it would be a completely different issue, not to say it and move on, but I guess I would, if I was at the state making that payment out of the general fund, the bigger question I'd ask is, what in the heck are you doing for $1,000 a day with that patient? Why is the cost so extremely high to put someone in the state hospital? That's medical services in general.
Yeah, and there, we can have an entirely different conversation about the cost of opening various wings and.
Yeah, get us completely sideways to today, but yeah.
So anyway, and to that point, the local mental health authority, you know, and I know that you all are working with Robbie, the new LIPSIC coordinator, shared between you all in Klamath County, to coordinate mental health with the criminal justice and juvenile justice systems, and your local LIPSIC. And again, you know, here we see a point where you can always decide to go above and beyond in services and programs provided, but there are some basics that have been laid out in statute there. And so this kind of gets to the broader piece. I can go through this fairly quickly, but you know, there are many ways that the CMHP or the LMHA, again, you know, is very similarly aligned with the local public health authority and your responsibilities there, that this is the safety net. This is really kind of the broad community health piece. So it is about ensuring that there are services available in the community, you know, that folks have access to care, largely that some of the prevention is done, right? And the more that we can do some of those front end services and try to prevent costs on the back end, not only from a return on investment standpoint, cost savings standpoint, but ultimately health outcomes, you know, we're gonna see better numbers there. And I will point out, partially because I find this interesting, it may be slightly less applicable, or maybe more actually, I'd be curious to get your thoughts. But the second bullet point around no person shall be denied community mental health services based on ability to pay. You know, that is one of the pieces that we hear from legislators a lot regarding community mental health. And I will say it's been interesting. Things have ebbed and flowed a little bit, but counties have not always been the favorite partner of our legislators in this respect. And the late Dr. Bates was kind of a big proponent of moving mental health care into the CCOs, taking everything out of the counties. A lot of that came from some personal experiences he had had in Jackson County as a physician. But we hear it, there are a handful of legislators who really struggle with the idea of access and the fact that they hear from constituents how hard it is to get mental health services in their community. And what we have found is that while in some cases that is true for the CMHP and the folks that you all are tasked with serving, it often comes from more of the commercial insurance side, where essentially they have commercial insurance, they've got their panel in the community, but there either aren't enough providers on the panel simply because of location and accessibility, or in some of our larger communities, you know, an insurance company is trying to keep their costs down by only having the bare minimum number of folks available. So we'll find folks who have private insurance but are having trouble getting access that way, who then come through the county door as sort of a last resort. And they do still then fall into the numbers, you know, of folks who are not getting served immediately, and they often contact their legislator and, you know, complain about how long it is taking, even though they are really not the folks that you all are designed with, or tasked with serving immediately. But that does come up, and so we often kind of push folks to really look at that question, even though it doesn't matter in terms of whether or not they eventually get services, but in terms of where they are sort of put on the triage list, we do encourage asking that question of who actually is the payer in a lot of those situations. And I recognize this is not legible from where you all are, but I will get you a handout of this, and I will get you the full PowerPoint. But this is just kind of a nice chart that does lay out, as you can see, both in terms of services and systems, a really quick bullet point list of some of the pieces that are in place in various areas around the state. There is not an expectation that you have all of these things 100% operating in your county, but this is kind of the quick hit list as you're looking at which services you would determine to be beneficial to your community that you would look at. And this is where we get into that piece a little more around decision making and looking at which services you're ultimately going to be providing. And this is, you know, somewhat of a rare benefit that we avoid the unfunded mandate, but that each community mental health program and developmental disabilities program shall provide or ensure the provision of the following services. But as we'll see, this is subject to the availability of funds. As you all know, most of that is going to be primarily state general funds. And I will say it often becomes an interesting conversation with legislators around the funding piece as well, because oftentimes the CCO will contract with the community mental health program, whether that be the county or a local nonprofit that the county has also contracted with. And so it gets very messy in the discussion of Medicaid versus non-Medicaid dollars. Because ultimately, when we talk about the local mental health authority and the community mental health program, and the folks that, those programs are really designed first and foremost to be serving, we are talking about a non-Medicaid population. Because really, the folks who are in a CCO or part of OHP, they're going to be paid for either through another provider or through a contract that the CCO would have with the CMHP. But it does make it a little challenging because the Medicaid conversation is obviously the larger one at the state level. So I'll pull these out here and then I'll kind of go back through. That's not all I wanted to do. Here, give me a second.
See what you can see.
Yeah.
You're welcome to put it through there too.
Yeah, let me.
So,
There we go. Okay, sorry about that.
It's all right.
So as we go through these pieces, different areas where requirements are going to come through. You've got your OARs, the state administrative rules, as we talked a little bit earlier, Medicaid rules and Medicare rules, different pieces that those will pay for versus not pay for. It's one of the things we've often struggled with and some of the issues with OHP and some of our contracts with CCOs, particularly around crisis services, where counties have to have some 24-hour services available, but it is tricky to bill for that because really with a lot of the CCOs, you're still billing on an encounter-based system, and so that kind of gets back to a question about the state hospital piece. When you still need to have your general operating costs built into what you're billing, how do you kind of find that balance and make it work with some of the Medicaid rules that are out there around what is payable and not. Similarly with private insurance, CCO, and really quickly, I am not the expert on the US DOJ agreement. And for a county of this size, it's not something that's going to have an immediate or on the ground impact, but just know that the way that the state has set up some of its rules, we've gotten hit by the US DOJ a couple of times by folks pushing lawsuits up or client complaints about services. And so there has been a big push between the state of Oregon and CMS, the Centers for Medicaid Services, to come up with an agreement about how mental health services are delivered and ensuring that folks are getting the services they need that have caused some changes in the OARs that are out there. So, and here's where we get to requirement to have your advisory committee appointed by you all. And then again, can determine the need and adopt a comprehensive local plan based on funds available. So within the limits of available funds, and some of the services, avoid hospitalization. And so this is really, actually I'm gonna spend a little bit more time focused in on this. When I talk about the issue of legislators coming back and complaining about folks who have gotten it or not, this is kind of that 3-point list that you can sort of fall back on as these are the individuals that we are statutorily tasked with serving in this prioritized manner. So those at risk of immediate hospitalization for mental or emotional illness, or services to avoid hospitalization, those at risk of harming themselves or others, children under age 18 who are at risk of removal from their homes. And then number 2, those least able to obtain assistance due to the nature of the illness, geographical location, or family income. Within that grouping is where we really kind of focus on the folks who are completely uninsured for whatever reason. Right, and we generally look at your OHP clients, in theory, should have access through their CCO and should be getting service through their CCO. So if you have 2 individuals walk through the door, one who is completely uninsured, one who is covered by the Oregon Health Plan, in theory, it would be the uninsured individual that you should be prioritizing in terms of getting services. That said, you would still take into account these other elements of risk of harm and severity of the services that they're needing. And then probably for the majority of folks, number 3, just those that will not require hospitalization. You're always going to prioritize the immediate safety and those with the highest acuity. And again, this was a presentation that was set up for all counties, but it really does, Commissioner, to our conversation earlier, get back to that. How do you decide where you're going to prioritize dollars, which programs you're going to fund, whether you're going to contract out or provide services in-house or partner with other counties? So size plays a role there. We do have mention of consumer and client advocacy, something you'll see quite a lot in the more metro areas where organizations like NAMI have a very large presence. The squeaky wheel gets the grease, so folks are going to prioritize some of those. And then also, folks' understanding of mental illness. Just like with any of the services, the county commissioners are providing what you understand the most is going to be easiest to come in and work on. And those are the problems that are intuitive to try to solve.
But understanding that, what I've seen over the years is 36 counties, commissioners change, come and go, they all gravitate to their expertise or whatever. And we end up across the state of Oregon with a few commissioners that their passion is mental health or that. But as a whole, most of us come in to our positions with no experience,
Right.
no knowledge, and really no, I hate to use the word drive to get to where it's saying there, which creates quite a challenge across the state of Oregon.
Right.
And just watching and looking at all this, and over the years I've read some of this stuff and all that, it's, for anybody new or old, such as me, it's pretty intimidating when you look at what all the true requirements are.
Right.
It fosters the thought, as general, why would we want to be the mental health authority,
Right.
state, and take it back?
Well, Commissioner, as you're saying that, I'm sitting here thinking, I'm not trying to draw a parallel, but it's one of the probably more, as you alluded to, unknown, but important, serious in nature. And yet, we're not the state police authority. We're not the state of Oregon Forestry Authority.
Right.
But we are the mental health authority. You know, how that ever came to be that those organizations don't exist on behalf of the state for those that know what's needed, know the ins and outs in the local communities or counties, just like other state
Sure.
organizations exist. Can't do anything about that, but it brings, your point was incredibly
It's,
important.
and that's the reason why we asked you here, to combine the three commissioners now. 40 some odd years of experience as
Right.
commissioners. But that doesn't make us any better as the mental health authority than a brand new commissioner at times. So it's pretty intimidating, to be perfectly honest with you, when you start looking at the ORSs, the requirements, and the potential for your community to be in trouble by not following all the exact program. Another thing is really a challenge, you get your funding in, but it's underfunded for the mandates that come with it. And so all that's quite a challenge. As you well know, you have one severe mental health issue within your community, it costs a lot of money.
Right.
And so, you've probably heard this from many
Yeah.
commissioners over the time.
No, it is. When I started with AOC, it was made very clear, right? Folks run for county commission, usually for economic development or transportation reasons. In Eastern Oregon, some of the land use and water pieces, right? I mean, the things that they're encountering in their everyday lives, or that they have folks, in their community, sort of their immediate community, right? That they're interacting with and seeing these problems that they want to solve. And mental health it's a bit more obscure in that regard. And I would say as a whole, it's still something that we talk about publicly, a lot less. There's still a certain stigma around mental health issues. And as it was an interesting question that came up for me that I realized I don't know the answer to in terms of when it was put into place, that local governments were the local mental health authority. I know that with public health, there's really a long history of that being driven by the local level. I know when Morgan gives her presentation on the history of public health, it goes back to housing and tenements in New York City and the need for clean drinking water and that sort of thing. But with mental health, we really have seen a change, just over the last half century of moving from large institutions to more community-based care. That I assume in some part has been the driving factor to moving that responsibility to the community, where it's no longer an environment where everyone goes to the state hospital, and a family may visit their loved one with a severe mental health issue, or may not. But we really are trying to serve those folks in the community and have more of that integration.
When you start putting it all together, it makes sense for us to be the mental health authority because it impacts our schools, it impacts our hospital, our jail, our law enforcement, right on down. Everything within the community can be impacted with mental illness.
But I agree, it doesn't make it any easier, just because it makes sense.
But it's pretty intimidating whenever you look at that. What works is a well-oiled machine with enough funding so that all those other services are less impacted because they get the right services to people with a mental illness. But you get to thinking about it, and it hits almost every part of your community at one time or another.
Yeah.
It's probably more important than most commissioners coming in having an idea.
Yeah.
And impacts more departments than adult probation, jail, on and on.
Not really,
Juvenile probation also.
I was gonna say, probably familiar, I started with AOC just right after they had wrapped up all the public safety summits that they were doing around the state. But that was really what started a lot of our work around public safety and mental health partnership. Because my understanding was that sheriffs across the state, the number one issue that they pointed out was our jails are full of folks with, you know, behavioral health problems, whether that's mental health or, you know, an alcohol and drug addiction.
Right.
You know, often you get folks with a little bit of both, because they're self-medicating if they have a mental health issue. You know, and recognizing, right, we just have these frequent flyers who are rotating in and out because they're not getting better in jail. We keep arresting them. You know, there's gotta be a better way to do this.
If I had the magic wand that would help is people that's within local jails
Mhm.
and at our state prisons, that's where the intensive mental health and alcohol and drug therapy went on. You know, when you pull them out of their environment out in the public and they're in there for one of the days, I've heard 21 days or longer after that 21 days, a lot of them depending on which substance they're addicted to. That is when you have the opportunity. But there's not enough dollars coming into the counties or any place to be able to have that intense program. Even in our institutions, our state institutions, we don't have that. And I think that's a component that's really missing on the behavior and mental health side of it. We're missing an opportunity there, my personal opinion.
Yeah, no, I mean, I won't disagree. The funding piece is, you know, always a challenge. And,
Well, it's creating that revolving door because they get out and they're right back in.
no, absolutely.
And
We're starting to, I think, to make some progress with some of our legislators, you know, in helping them similarly understand the role of the community mental health programs and where that kind of fits within the larger system, and helping to see some value there, but it's still a slow process. We have another 20 million for community mental health this year, which is great.
Well, and I don't think, I think it's going to
split between
continue to grow with the issues with the addiction, some of the drugs and addictions that's out there now. It's the impacts on mental illness, behavioral health is more than it was even 10 years ago. And I think it's going to continue, as we all know, generational.
Yeah. No, absolutely. It's a bit of a digression, but it's one of my frustrations with the need for the state to have a balance two-year budget. While I understand it, you know, it also means that we look at funding on a two-year level and are not as able to take into consideration, you know, the longer-term cost savings of making an upfront investment in something.
Yep, being able to have that vision in the future as to how we actually will cut costs and remove a lot of the issues that plague our communities and our citizens. Because we can't make that investment, but yet we make it on an annual basis because of that revolving door. We continue to spend the money, it's just, we need the major programs in place that cost us up front, that save us long-term millions and
Sounds
millions.
like you're talking about our forest health.
Well, yeah. I mean, just about it. Yeah, there you go.
Yeah,
Yeah.
no, it's, I mean, it's a challenge across the board.
It is, it really is. I didn't mean to take it sideways, I just.
That's a good discussion.
Yeah, no, and so again, and so looking at the funding streams, right, we do see a lot of partnership with CCOs, but that does vary from community to community. I know that Gobi is sort of the mental health component of Eastern Oregon CCO. You know, they're very highly thought of, do a lot of great work, sort of my outsider observation in Eastern Oregon. And so I think you all are sort of fortunate to have that as a resource compared to some other CCOs that tend to be a little bit more insular in their work. State or specialized demonstration project funding. So that's where you would see, even with this 20 million that was added to community mental health this session or last session, there was about 24 million between various programs that was available. And a good chunk of that was divided into jail diversion, addictions treatment, some housing supports, and it all went out via an RFP process. So that's where you'd see, you know, the pilot project or competitive grant funding pieces from the state. Or there are a few areas around the state that are part of a demonstration project around certified community behavioral health homes. And I'm not an expert in that area, but it is something to know that is out there. And then local funding, where again, you know, different communities of different sizes will have more or less resources to put in locally acquired grants or projects. And so here's where we get to kind of the three, large elements where the county provides everything directly. For the most part, that'll be your larger counties that have the capacity, and have a full-size health and human services department. The county contracts the private agency to provide the services, designates this agency as the community mental health program, and then
That clarifies the question earlier.
And then the county can contract out various services to multiple agencies where you would still retain your coordination. I think for some counties that may be the right fit, just based on service providers who are available. But I would say that's probably going to be the messiest of those options, right? Where you still kind of have all of that oversight function. And it's actually going to take a little more staff time to do that and ensure that that's being coordinated by multiple agencies. And then the regional groupings for provision of services, acute care regions, multi-county CCO partnerships. And one piece that I will add into this, I was going to pull a budget note language and I forgot, but in the OHA budget that just passed, we had a behavioral health work group, or commission, I guess rather, that was convened by OHA, about 50 members during this last interim, to look at the behavioral health system overall, statewide. And one of the recommendations that came out of that group was that there should be some sort of regional governance model around behavioral health. Sort of the examples that were thrown out, I think one that was really held up as kind of a marker was the Central Oregon Health Council that kind of oversees a lot of not just behavioral health, but different health systems within that area of Deschutes, Jefferson. So there was discussion about whether or not there was going to be legislation to require regional governments, and they sort of settled with a budget note that directs the Oregon Health Authority over this coming biennium to begin the discussion and the rulemaking process around having a regional form of government for behavioral health, which essentially would be about bringing CCOs, your CMHPs, LMHAs to the table. I believe public health was called out in that, as well as some of your public safety and education stakeholders as well. So just know that we don't really have a lot of answers about that. We have budget note language and have directed to the agency to come back to the legislature, but and I know that there is a work group as part of the Behavioral Health Collaborative that is continuing to have those discussions about what would this regional model look like. And my understanding is the ultimate hope would be that that would be a body that would kind of help direct funds that are available at the state level and kind of determine the best use of resources between various entities at the local level. Civil commitment and the role of the county. And this is a big one, probably doesn't come up often, but when it does, it's pretty vital. So your community mental health program is responsible for conducting investigations. So again, civil commitment, we kind of have two populations at the state hospital. We have what we call the 370 folks. And those are folks who are sent on aid and assist because they've been accused of a crime and they are unable to aid and assist in their defense. And then there is the civil commitment population. And those folks who have either potentially identified themselves as needing a high level of care, or more often someone in their community or a relative has said that this person is unable to care for themselves and needs some severe care. So when that happens, someone is put under, for example, a 72-hour hold by a mental health professional who determines that they're of harm to themselves or others. It would be up to the community mental health program to make sure that that evaluation and investigation gets done on that person to determine their sort of mental health status at the time. And you can see some of those further responsibilities laid out there. And the last piece, particularly in some of our mid to larger counties, determine if there's a least restrictive treatment option available. Again, that's where we see the importance of community-based care and trying to stem the tide of folks going to the state hospital, right? Where it's not just a matter of, say, oh, this person is mentally ill, we're gonna send them to the state hospital, but really taking a look at the community to determine if there's some program locally that would actually meet that person's needs without them meeting the acuity of care that is provided at the state hospital. And that's where we feed into managing the state hospital population. So for folks going to the state hospital or coming out, the community mental health program has a responsibility to kind of manage those transitions and ensure that for someone who is coming back to their community after being discharged from the state hospital, that there's a connection to services there and that there is that warm handoff so that we don't just continue that revolving door. And those are just some of the systems that would fall in with that, ensuring that is available. The 24-hour crisis response system, I would say that's one of the areas that we've garnered a lot of attention in working with the legislature, because it's often where we see a lot of that partnership with public safety. So you can see that statutorily, folks are, there's a responsibility to have some sort of 24-hour crisis response system. But that may look very, very differently. So whether, as you see in that third bullet, whether it's a 24-hour phone line, mobile crisis teams, that's where we have a mental health professional and a public safety officer who are partnered up, who will respond to things 24 hours a day. Triage centers, drop-in centers, some folks have a warm line, and things of that nature. And so that can be, as mentioned there, you can braid funds to do that. Oregon Health Plan, State and County General Fund. That's an area, as I mentioned previously, where sometimes we have challenges with billing of the CCOs, but they do have a financial responsibility to help cover some of that 24-hour crisis care, because ultimately it is part of their health system, and part of what helps them get toward their goal of AAA with having better health outcomes. And
yeah, I'm sort of surprised to see general fund funding streams that it's written in there on the 24-hour crisis response. That's so expensive to do. You're talking 24 hours, 365 days a year. Even if it's just somebody having to pack a phone, there's quite a cost.
yes,
That adds up over the 365 days, especially weekends.
right.
And after hours. But I wasn't aware, never seen that general fund funding stream.
Yeah, so I mean, I would read it, I would read that as there is not a specific requirement for the county to invest in those dollars, except that there is a requirement that there is some sort of 24-hour crisis service available. So absent the ability to cover that through other funds, right, that's going to fall back on the county general fund budget. But it is not prescriptive in terms of how those funds get rated or what portion comes from any given source. And this is just kind of a quick chart that very high level sort of outlines, state funding has responsibility for the state hospital, specialty residential services, indigent acute hospitalization, so we're in the county acute care region, so involvement with the CCOs. And then for your Oregon Health Plan specifically, the funding goes through the CCO, and then the CCO is either going to contract with the county for some of those mental health services through the CMHP, other providers in their community. And then over here you can see for non-OHP, and this is where I was talking about that piece that is non-Medicaid dollars, those funds come directly from the state down to the county. And then you could potentially provide those on your own if you wanted, but most likely folks end up subcontracting out to local nonprofits to provide those services. So mental health, alcohol and addictions, and then the developmental disabilities piece. And this is where again, we see some of that language around partnering with the CCOs. As I mentioned, we seem to see a lot more of the requirement on local governments or other stakeholders than the CCOs actually have put upon them. But again, you all are fortunate that with EO, CCO, and GOBI, there is a large willingness to partner and have those local conversations. We do see this in varying areas where someone from the county sits on the CCO governing board, and as part of their CAC, the Community Advisory Council of the CCO. And then the CCO does conduct community health assessments, the health improvement plans, and those various pieces. But, they do often need some involvement from the county in their data collection, and putting those pieces together. And these are, I won't spend a lot of time there, these are just kind of some of the benefits of having a strong partnership with the CCO. And I will say, just for sort of context around this, Silas, who, he is the Health and Human Services Director in Yamhill County, but is also the current president of the Association of Community Mental Health Programs, and he does have a seat on his CCO board, so he kind of has that perspective of what it means to really have that broad view of the best way to partner. And he, if you're around AOC conferences, probably more than our monthly meetings, but has been pretty involved, especially around some of the pieces regarding public safety involvement, because he does have a public safety background as well. So he's a great resource to have on hand when we do have questions about how to go about providing some of these services or think creatively about things like that. In the interest of time, I'll kind of skip through just some of those opportunities for partnership. And these are some of the pieces that we focused on very recently with the public safety partnership, jail and state hospital diversion, residential for behavioral health, housing, as you know, is an increasingly talked about issue statewide, both for vulnerable populations as well as the population as a whole. But we do see that need for increased supportive housing, for folks who would otherwise need to be in residential care, but can maybe get by with a small level of assistance throughout their day. I've already talked about most of these pieces. So I have included the contact information there. As we mentioned, I'm available through mid-August, and then we'll be departing AOC. Andy Smith is going to be taking over Health and Human Services. Which he actually, so he has a background in that. He worked for the Association of Community Mental Health Programs prior to being with AOC full-time, so he has both the vets and HHS perspective. But as we were discussing before you came in, Commissioner Winters, I think at the August retreat, AOC will be doing a lot of kind of revisioning of the policy priorities that we focus on going forward. So I'm not honestly sure how Andy's time will really be dedicated between County Solutions and Health and Human Services. So for the time being, I've kind of left Mike as the go-to for questions around community mental health or local mental health authority issues once I leave. And then Cheryl Ramirez is the Executive Director of the Association of Community Mental Health Programs, and she's a great resource as well. In terms of just depth of knowledge of what different counties work on across the state, how they have set up their systems. I would say it's almost 50-50 in terms of folks who in-house are the CMHP and then those who contract out with other nonprofits. It's definitely not rare. And I will say, and I can pass along her information in a less formal way, but I believe Kimberly Lindsay has been willing to help out as the hospital makes this transition. And she's an incredible resource and has done some fabulous things. And
we contracted with her.
Yeah, and she's,
transition.
I think to that question of, counties having that authority, particularly for rural counties, I kind of point to Kimberly as an example of having really taken advantage of some of the unexpected benefits of a small community and the relationships and partnerships that exist there to rally the funds and just kind of that stick-to-itiveness for some of the programs that she's put together in John Day. They've got Juniper Ridge, which is the acute care, before folks would need to go to the state hospital, residential site, and then Lakeview Ridge up in Hefner for folks who are transitioning out of that higher level of acuity of care. And, both are incredible facilities, and that's something that
There's just not enough of Kimberly to go around.
Right, right,
Honestly.
but that's, it is, I mean, and we face that workforce challenge statewide, and it's something that AOC is, as a whole, looking at workforce, but also within, sort of the health-specific field, that has a big impact on our counties.
It's interesting, Stacy, I'm gonna go back just a step. When you had the breakdown of county ran and county contract with other service providers 50/50, one of
It's a
the,
rough estimate.
yeah, but one of the points that we looked at in the Eastern Oregon Coordinated Care, our understanding was, prior to our contracting with the hospital, the district, like
Mhm.
health district, we were the only county that wasn't doing that within that framework. So there must be a lot of county organizations, county-ran organizations on the west side of the state, because in Eastern Oregon, most all of them are contracted.
Yes. Yeah, no, that is true. I think a lot of, I know at least 3 utilize Kimberly as their
Mhm.
director through Community Counseling Solutions. So, yes, I think our rural counties do tend to contract out more often.
It's ever evolving. I mean, we both go, when Commissioner Shannon first came on, we used to contract out, it was just transitioning over to county operations right at 10 years ago. We've done a pretty good shot at it, but it's a challenge for rural communities to attract and be able to get the directors here that can stay with all that and hold them here and so on, to avoid a cycle. We honestly really believe we're in a better position now contracting it out. We gave it an honest, good shot.
Sure.
But I think we're going the direction that's going to help our community and our clients out there.
Yeah.
They'll be better served.
Well, and to your point, Commissioner, it's more of the whole model when we switched over to the whole coordinated care organization model. That's where we're at, because we have all the care, you might say, coordinated.
Right.
Because of who the providers are.
Yeah, and there's nothing wrong with the contracting out model, by any means. And I think, from the AOC perspective, we always support folks doing what works for their local community, and we recognize that, there have been times when it has made sense for various reasons for folks to hand things back to the state, but we do try to find other solutions like the local contracting or, I think one of the areas where folks have kind of been watching Lake County to a certain degree is the use of, the district hospital versus just a nonprofit. So there's always kind of that interesting piece of working with another governmental entity on some of those governmental responsibilities.
As Commissioner Winters just alluded to, Stacy, with that, a year and a half ago, we kind of got, as a board, the situation handed back to the board, and Commissioner Winters picked up the ball along with Denise and a few other folks. Were able to sit down and craft a plan. So Lake County, I think, does bear watching from that standpoint, because I do think, take away any personalities or any of that kind of stuff, but the actual model just makes a lot of sense.
Yeah.
And I'm really happy that we're on the path we're on.
I am too. We had Kimberly and Chris on.
Oh, yeah.
And Chris.
They-
And we, it was with plenty of challenges. And the reason why we have you here today is because of, even with all of our years of experience, we're no expert. And whenever you contract out, then we're still the mental health authority. What does that really mean as commissioner? And we want to make sure and try to do and stay in compliance.
Yeah.
And do the part that we're governed to do. I have to be perfectly honest with you, even with your presentation, it's still intimidating. Whenever you really start breaking it down and everything, it's like, oh, we're going to rely on our contractor to make sure and help us guide us through all this in our advisory board and this and that. But I see components in there that it's like, oh, like Lipsy component. When I was liaison for the sheriff's and the DA side, I sat on Lipsy for several years. It's like, I'm not sure we're hitting that component as well. It can be hit because that's the whole group of people that sees the impact of mental health. They're all at the table there in those meetings.
Yeah.
Can we do better in places? Absolutely, and that's the reason why we're having this meeting today, is for us to try to make sure that we can capture some of those things that could be done a little better, so.
Sure. Well, I appreciate that. And, you know, if there are more, you know, detailed specific questions about, you know, certain service elements and, you know, how you are or are not providing those, or, you know, always feel free to reach out to us, or,
Commissioner Winter's comment earlier about the advisory board, I know your time is short relatively speaking, but boy, I think it would be wonderful if we could get Stacy back here.
I would really like to try to, not for a public meeting for the Board of Commissioners, but for the advisory group and our contractor, which is on our advisory group, for us to be able to maybe even show some of the responsibilities of the advisory group a little bit more broad maybe, but if your travel would allow, and if we could get that organized, that would be very good.
yeah. Yeah, I mean, I'm happy to try to make that work. You know, and I might check into with Kimberly and see if she's able to, depending on her schedule, join me for that, since she has at least a relatively local-ish face who will be, you know, continuing on. You know, it's helpful for folks to kind of make that connection with her as well.
Yeah, it's, middle of August isn't far away.
It's not.
It is not indeed. It is not indeed.
Now we start doing all the things that.
I wasn't able to make the last mental health advisory board meeting. We should have another one coming up.
Yeah, you know, and I would be willing, yeah, my official duties go through the end of the retreat, but I'm still technically on payroll through the end of the month, so, and I'd be, you know, I'd be happy to make the trip back down. You know.
Well, you know, as I told you before the meeting started, and I haven't told Commissioner Winters yet, I mentioned it to Denise yesterday, I'm gonna be at that meeting, because I, you know, talked to Mike, and there's a lot of, for the legislative committee, representing perhaps the whole state, you know, commissioners, there's a lot of stuff that's gonna happen. A lot of positions or programs that need to be determined, even while Mike's announcement last week suggested some things have been determined. I think as a group, we need to really think this through on where do we need to spend the few resources we do have, or the reduced resources we have because of Jackson County's departure of AOC. That's what's precipitating a lot of this. And, you know, as we look at the new model of AOC's delivery of services, I can't imagine in this day and age, there's a whole bunch of number ones, but I don't know that there's any one number one more important than what we were just discussing.
It impacts almost every single component of our communities at some level.
Yeah.
I will say my understanding from some of the discussion in August and conversations with Mike, I think there is a little bit of discussion between, you know, AOC's division of work and priorities, but particularly between how much AOC dedicates in terms of advocacy at the state level, and then how much staff time is focused on acting more as a resource for our members. I think if you look at you know, some of the county solutions programs of, you know, acting as a convener for local meetings, and these sorts of you know, trips down here, and kind of having that question of, does it make sense to have a staff person who is available, you know, all of the time to go out and have these meetings? And I know you all had you know, requested this meeting some time ago in the legislative session. It just wasn't able to get down here. But it's, I think, a question of, you know, okay, well, does it really make sense that we have someone at the legislative level, you know, working on these issues, or is it more important that we have someone who's available to go out and meet with members as needed?
Well, what you're just saying there, Stacy, you know, we've talked about it before, because we don't feel like we're left out, because we have the ability to drive to Salem anytime, but it's kind of ironic that some of the best information and exchange of understanding of what counties really are dealing with happens when staff comes to the counties.
Sure.
And, you know, I would like to see us narrow the number of organizational pieces we have, and I know it's already been talked about, it was in there too. But I will, you know, I was the chair of public lands for a period of time, And, you know, right next door was the Environment and Energy Essentially Committee, which was pretty much all public land related. And so you had staffing both of those. And
Right.
I would like to see that scope narrowed a little bit, but then really get the AOC staff on the road more.
Mhm.
You know, getting out to multiple counties in a 2 or 3 day trip.
Yeah.
And then when they go back, you know, they really understand what the issues are in these counties and what's important and what isn't.
Well, use me as an example. I'm the least traveled commissioner with the most
Well, you have
longevity.
the most miles on you.
Yeah, with the most longevity.
Uh-huh.
And you're probably not going to change me. I'm probably not going to get involved at the AOC
Sure.
level very much. But for my community, it's very near and dear, and I'm very dedicated to that. So I'm with Commissioner Shell.
Yeah.
I would like to see AOC able to get out on the road more and get to our communities. It is a challenge for you to come here. Turn it around. It's a challenge for us to be out of our county for 2 days
Yeah.
and everything. So I'm individual commissioner, and my personality and my lack of wanting to travel. I would love to see AOC present with the counties a little more often.
Yeah. So
Well,
it's-
and even though you don't control those decisions, that's one of the reasons that I'm gonna go over
Mhm.
to meet. Because we as counties and commissioners need to share that with the administrative oversight of
Yeah.
AOC.
Yeah, and I think, you know, I mentioned that just because, Mike shared that with me, you know, that is part of his thinking of, you know, how much should we focus on advocacy versus other ways to serve members, and, you know, even though we discussed there might have been a variety of issues, surrounding Jackson County's decision to drop their membership, I think it always begs that question, you know, for the association to ask, are we serving our members in the best way, possible and in the way that they really need? And so I think that is the goal of the conversation in August, is to make sure that we're best aligning with, you know, what you all need from us.
Well, it gives us a chance to reset our foundation as an organization through this, because, you know, not to belabor the discussion and continue our meeting longer than it needs to, but having been involved in all those levels, you know, and it's not like I'm some tenured, you know, real intuitive person on this, but through my governmental experience for 32 years and then as a county commissioner for going on 11, you know, I see we got way too wide, not for our organization itself, but for our outreach. I mean, we're running all over the world. You might say, well, we are running all over the world. And I think we need to come back and build our foundation strong here in the state. And not, you know, not to say that some of those things can't be beneficial, but we were just fractured. So that's gonna be my message over there, and how we get to where we get, determining the services we think AOC should be providing, or how they provide those, how they outreach, et cetera. Because we enjoy it when AOC is able to come down and spend
Sure.
some time here and really see what's going on.
Yeah.
Because then when they go back, there's a clear vision for what they can do to help us.
Yeah, it's helpful.
Yeah.
And it was one of the things, it was a little surprising for me, you know, just how much I traveled when I came to AOC, just within the state. Previous jobs, you know, lots of DC trips, but not much in-state travel. And, you know, prior, I mean, I think I passed through Burns on the way to Winnemucca once or twice, but, you know, I had my first trip to John Day with AOC, and yeah, it does, it makes a difference, you know, to get out and see those different communities, so.
I'll say it because he's thinking that John Day's a beautiful place, that area. He was raised in
John
Prairie
Day's
City.
Prairie City.
Well, the drive out there was beautiful.
It is, it is.
You know, but yeah, I mean, even as an Oregon native, you
Yeah.
know, there are parts of the state that I had never been to.
Well,
so.
Prairie City and John Day used to have this real rivalry. Growing up in Prairie City, I always.
I consider it all John Day. He corrects me.
Yeah.
Yeah,
No, I understand that. So yeah, I just end that with, you know, we're, regardless of, you know, who is doing human services, or what that looks like at AOC, I know we're always happy to be a resource, and AOC MHP, as well. They have the depth of knowledge, really are just focused in on the LMHA and CMHP responsibilities, work very closely with OHA. Just another resource, I don't know how much you all interact with Bobby Green at OHA, but he's,
From time to time.
yeah, I mean, if you have a question, he's happy to kind of help find the right person at OHA to answer that. And then I would say, maybe flag, just for your county councils that, when you get the contract from the state, around, acting as a local mental health authority, that's where you're gonna see some of the specifics around, referred to in the contract as the service elements that you all are expected to be providing. And that's an opportunity where you can kind of have that back and forth with the state, on an individual level about what makes sense, what's feasible, what's not, and then pull your contractor in to evaluate that contract as well.
Yeah.
So thank you all for inviting me down.
Thank you for coming,
Well,
Stacy. Thanks for the
thank you.
presentation. Yeah.
Great presentation. Denise will have a copy of this.
Yeah, I'll get that over to her. Like I said, I can't take credit for the slides, I just,
Well, you said that up front.
yeah,
but you
took
presented
advantage of
well.
Silas's good work with
Yeah.
PowerPoint.
Very well.
So how do we make sure we coordinate the chance that we might be able to get near the board?
Denise will
together?
probably get a hold of Mary Oakley that coordinates our mental health advisory and see when their next meeting is and see if there's a way to coordinate that with
Okay.
Stacy.
Yeah, I can let you know if there are specific dates that I, have unavailable due to other things, but
Yeah.
otherwise if you wanna
So you work.
let me know when you're available and I can do what I can to make that work.
Sure.
Well, thank you very much, Stacy.
Alrighty, thank you.
Thank you.
So Commissioner, if there's nothing else that needs to come before the board for this work session on July 18th, we're going to adjourn at 11:22.
Very good.